All right. It looks as though everybody has been able to join. It might be that a few more people are going to join us along the way. But thank you so much for being here today. Thank you for being so prompt and on time. We have a really important topic today, and so I'm excited to share that with you. Just a couple of housekeeping things to begin with. This is our last webinar for a couple of months. If hopefully all of you know that our conference is taking place next month. And so we will be taking off likely August and September from webinars, but you can keep an eye out on our website and on our emails. And most likely we will be starting those back up in October. So just an FYI on that. Another FYI about the conference. So that the conference is in Reno, Nevada this year. It begins August 30th, and early bird pricing for registration ends on Monday. So if you have been waiting to get registered and you still want to get that early bird pricing, please do so by Monday. And hope to see all of you in Reno. It's going to be a really great time and a really great opportunity to network and have great education. So would love to see you all there. Turning things to today's webinar, I know that Zoom has done some a little bit different things with the Q&A. We do prefer to have all the questions for our presenters in the Q&A section. And so it's possible on my computer, I had to go to the More button at the bottom of the page and then click on the Q&A from there. So if you're looking for it, that is likely where it is hiding, as it was hiding on my computer. In addition to that, though, if you want to interact with the other people that are here in the webinar, you certainly are welcome to chat. And so the chat feature is on, and everybody can access that there. But again, if you have questions for the presenters, they're graciously wanting to take your questions. Please put those in the Q&A. So with that said, I am going to be quiet myself, and I'm going to turn things over to our wonderful panelists, and we'll start with Lindsay Wilson.
And Lindsay, you're muted.
You would think by now. Again, welcome everyone. As everyone see my slides? Perfect. All right. Well, thanks, Wendy, again so much for having us here. This might be a little different than kind of your usually scheduled programming, but again, myself and my colleague, Dr. Sydney Fox, are really excited to be here to talk to you all about something that's really near and dear to our hearts. As you see by the title, our goal is to help you all gain a better understanding of addiction. So we're going to provide an overview of things that increase and decrease the risk of fatal and non-fatal overdose. And my colleague, Dr. Sydney Fox, will walk through some strategies a little more specific to your field. Very quickly, a federal acknowledgement from our organization and funders. The views for my colleague and myself are our own and do not represent the official views, nor are endorsed by the CDC, HHS, the US government, or the CDC Foundation. So for a quick round of introductions, as I said, my name is Lindsay Wilson. I'm the training technical advisor for the National Overdose Response Strategy. My parent organization is the CDC Foundation. A little bit of background about myself. In this role as a training technical advisor, I'm fortunate to do national training for the Overdose Response Strategy program, which you'll get to learn a little bit more about what that looks like in the presentation. I also serve as a technical advisor for a subset of 8 states across the country and lead the Justice Continuum Overdose Prevention Learning Community. Again, you'll learn more about this, so that'll make a little more sense later on in the presentation. Prior to that, I served as a public health analyst for Illinois, and then worked in local public health before that. And before that, I was in the military, so have a unique background. So with that, I'm going to pass it over to Dr. Sydney Fox to introduce herself.
All right. Thanks, Lindsay. As she said, I'm Sydney Fox. I'm also a technical advisor for the CDC Foundation working on the Overdose Response Strategy program. I lead the overdose prevention and policy learning community, and I also serve as a subject matter expert in overdose prevention and drug policy, and I support jurisdictions in implementing evidence-based, locally responsive strategies. My work primarily focuses on translating research into practice and advancing sustainable systems-level solutions. My background is I hold a bachelor's degree in criminal justice and a master's in public administration, as well as my PhD in public policy and administration. And before I came to work for the ORS about 6.5 years ago, I actually worked for the Idaho Supreme Court. So I have some experience in court administration. Back to Lindsay.
Great. Thanks so much, Sydney. So as we start, we're going to kind of sandwich some ORS specific information, or not really sandwich. We're going to open and close with some ORS specific information. And Dr. Fox is going to talk through kind of more of those specific strategies in between. So just so you all are kind of aware of our program and understand how we work and how to connect with us, I'm going to start with a broad overview of the overdose response strategy. So the primary aim of our program, or the mission, is to help communities reduce fatal and non-fatal overdose by connecting public health and public safety agencies, sharing information, and implementing effective strategies. Just to give kind of an overview of what our program looks like, there's many players and many arms to this program. The core of our program really is the ORS team. We have a team of public health analysts and drug intelligence officers, 61 of them in every US state and territory, as you can kind of see on the slide. Looking at the drug intelligence officer, or the public safety arm of our program, our drug intelligence officers are supported and funded through the high intensity drug trafficking areas. If you're not familiar with those, the primary aim of those organizations, the HIDAs, are to reduce drug trafficking and production in the United States. And they achieve that by fostering cooperation among federal, state, local, and tribal law enforcement agencies, really focusing on sharing intelligence, coordinating enforcement operations, and really maximizing available resources. So if you're not familiar with the HIDA program, that's a very quick overview. And they're funded through, on the national side, from the Office of National Drug Control Policy. On the public health side, our public health analysts are employed and supported through the CDC Foundation, and the CDC Foundation receives federal funding from the CDC through a cooperative grant. So just so you can have kind of a snapshot of how our program is made up and the mission of our program. But really, I want to talk a little bit more about the core of our program, which is our ORS teams. The heart of the ORS is our state-based teams. It's made up of the public health analyst, or the PHA, and the drug intelligence officer, as I said before. And really together, they work at that nexus of public health and public safety to support overdose prevention across the country. Looking more closely at the public health analysts, they could bring the expertise in public health data, prevention strategies, program implementation, and are really great at fostering those community partnerships. They work closely with health departments, healthcare systems, community organizations, and other partners to identify trends, strengthen collaboration, and support evidence-informed overdose prevention efforts. Our public safety partners, our drug intelligence officers, really bring expertise from that public safety side and their connections. They're typically housed within the HIDA, as I said before. Sometimes they're within a state fusion center. And their role is to help identifying emerging drug threats, trafficking trends, and intelligence that can inform local response efforts. They also leverage the nationwide network of DIOs to share information across jurisdictions and state lines when it calls for it. And together, the PHA DIO team combine public health and public safety perspectives to help communities make informed decisions, strengthen partnerships, and implement effective overdose prevention strategies. One thing I have to plug is, if any of your agencies are interested in connecting with our ORS teams, I highly recommend it. I'll give you some information later on in the presentation on how you can do that. So just a little more on our teams, again, because they really are the core of our program. There's a lot of metaphors that are used to describe our teams, but these are the ones that really resonate the most. So when we're talking about a guide, oftentimes public health, public safety partnerships are a new adventure for partners that we're working with. And in many ways, the ORS team is that guide to help them learn what this public health, public safety collaboration can look like, how to make it data-driven, and how to make it effective. Connectors, absolutely. Our teams are those bridges and connectors. They bring people together. They help people understand kind of who needs to be at their table and when. And then again, going on to that bridge, the team itself serves as that bridge between agencies. They can sit in the room together and speak that language for the public safety or the public health to bring both sides together and help them really see what the overall mission or vision is for the project or strategy that they're working on. Translator, absolutely. This is one we talk about a lot. When you think about public health and public safety, language can mean very different things. For example, surveillance in public health is very different than surveillance in public safety. And the ORS team is able to sit at the table and help translate those different terms and ways of thinking into ways that are actionable and a way forward, as I've talked about before. And a diplomat. This is really kind of the heart of what the team is. They serve as that example of what effective and successful public health and public safety partnership can look like. And they can help communicate that really to their partners and to help them bring them to that understanding. Because I'm sure you all know that everybody's coming from different walks of life with different skill sets and might not have the same ideals initially coming to the table. And our teams can really be that diplomat to help people see the why and why it's important to be at the table. So just kind of some really hyping up our ORS teams because they do an amazing job of bringing people together to address overdose across the country. I'm not going to dive too deep into this, but I wanted to provide a simplified snapshot of how we work towards our end goal, or as we lovingly call it, our North Star. The majority of the work our teams do fall within these 4 core strategies: sharing data, building partnerships, providing education, and helping communities implement evidence-informed solutions. While these strategies are shown separately, they often overlap and reinforce one another. Together, they strengthen the collaboration between public health and public safety, as well as our justice partners, so communities are better equipped to prevent fatal and non-fatal overdose. Over the next few slides, I'll briefly walk through each of the strategies just to give you a sense on how our ORS teams can support agencies like yours and how they accomplish the work that they do. So looking at the share and connect strategy, data is the foundation of everything that ORS does. Really, we try to be evidence-informed and data-driven. Our teams help communities bring together public health and public safety data really to better understand the local overdose trends, identify emerging threats, and make informed decisions. Our teams are able to translate complex information into actionable products like data briefs and dashboards, presentations. And later in today's presentation, I'll share one example of how we do that nationally with our Trends Analysis and Threats Call, which provides timely information on emerging drug trends across the country. Next, the Collaborate strategy. As you've probably gathered from the previous slides, the ORS is built on collaboration. Our organization's role is really to strengthen existing partnerships, build new ones, and identify opportunities to bring the right people together around overdose prevention and response. You may have heard the phrase breaking down silos before. I know that's kind of a buzz phrase, but that's really exactly what we aim to do with this program. We connect public health, public safety, and justice partners so they can share information, solve problems, and develop coordinated responses. That's one of the reasons I'm really excited today to be here. The pretrial community is a newer partner for the ORS, and we see a tremendous opportunity to work together to improve outcomes for individuals and communities that we all serve. Inform and promote this strategy. Education is one of the primary ways the ORS supports communities, and our teams provide trainings for public health, public safety, justice partners, and others on emerging drug trends, addiction, overdose prevention, and evidence-informed practices. In fact, today's session really is an example of that work. By sharing knowledge and building awareness, we help our partners make more informed decisions and really strengthen their local overdose prevention efforts. And lastly, help and implement. This is where the collaboration becomes action. After helping partners build relationships and share information, the ORS is able to provide technical assistance to develop, implement, and evaluate evidence-informed overdose strategies, whether supporting diversion efforts, staff education, or connecting justice partners with public health resources. Our goal is to help communities move from that planning to that implementation stage. And so with that, I hope I've done an adequate job of describing the ORS program, how we operate, and hopefully you got your brains thinking on how you might want to or be able to collaborate with the team in your state. So I'm excited to pass the mic over to my colleague, Dr. Fox, who will dive deeper into addiction and overdose, along with some practical strategies for the work that you all do. On to you, Sydney.
Awesome. Thanks, Lindsay. So I want everybody to be aware that there will be a practice as we go. So just a reminder that it's a great time to pay attention. I want to definitely have an opportunity for you guys to just be thinking through some ways that you might be able to change your workflows. Just as a brief overview of what I'm going to talk about. So first, we're going to talk about why pretrial services is such a high leverage point for overdose prevention. Then we're going to look at what changes overdose risk. So not just whether or not someone is actually using substances, but what's changed in their lives. Has their tolerance changed? Treatment access, stress, things like housing, drug supply exposure, and social support. These are all important things that go, to that risk itself. Then we're going to talk about 5 evidence-based supportive services levers that you guys can actually integrate that may trigger or support your work in terms of overdose prevention. So we'll talk about naloxone, MOUD continuity, overdose safety planning, warm handoffs, and then data informed coordination. And then we're going to translate those into workflow itself. So that through line is role clarity. Pretrial services obviously doesn't have to deliver each intervention, but just being aware of where you can identify risk early on and then reduce immediate danger, protect treatment access, and then just making sure that those connections are real. So next slide, Lindsay. So the reason that pretrial matters in terms of overdose prevention is timing. So overdose risk is not static. It can change quickly around arrest, booking, detention, release, court events, and community supervision. A person may move from a controlled environment back into the community in a matter of hours, and sometimes without medication continuity, they may not have transportation, they may not have access to a phone. They may not have their identification or even a safe place to stay. And so pretrial services may be one of those first structured community contacts after that transition happens. And that doesn't mean that pretrial owns the overdose crisis, right? It just means that you guys may have access to a window where these small actions can have a huge impact. So this is more or less talking about the practical opportunities to turn a justice contact into a safety and a connection contact for people. So that can mean asking like a brief risk question. It can mean offering naloxone, confirming that they have access to medications, making a warm handoff potentially, as well as alerting a partner to a system barrier that keeps coming up because you have those visual points frequently. Next slide. So the first concept that I really want to anchor is that addiction is a chronic treatable health condition. That matters for pretrial because it changes how we interpret behavior. Return to use, missed appointments, withdrawal, or difficulty following through may actually signal risk or perhaps instability for folks, maybe even some barriers, and that should trigger assessment and support, not only punishment. Overdose risk is dynamic. So it goes up when tolerance changes. It can go up when MOUD treatment is interrupted. And when I say MOUD, I mean medications for opioid use disorder. I probably should have mentioned that. I'm going to try and not have just the acronyms. So apologies on that. And then also after a recent overdose, risk also goes up when someone is withdrawing or when they may be exposed to a volatile drug supply. And then justice transitions can intensify all of these because they add stress. There may be housing instability, transportation barriers, like I said, loss of phone. There's obligations when it comes to court, and then also fear of consequences. So one helpful question that may be asked is to always approach it as what has changed since the last contact? And then that next question becomes, what is the best safety action that we can take right now? Next slide. So these are the 5 levers that I would prioritize when it comes to this particular audience. So first, we want to equip people with naloxone and basic overdose response knowledge. Second, connecting people to medications for opioid use disorder and protecting medication continuity. Third is use overdose safety planning so that people have a concrete plan for the next high risk moment. Fourth is replace passive referrals with warm handoffs. Fifth is partner on data informed prevention so that agencies can see patterns and then respond earlier. But notice that not all of these like programs are pretrial ownership, right? Some are direct practices that you may be able to include in workflow. But then a lot of them, and most of them perhaps, are partnership functions. And so the implementation test is then whether the strategy is routine, easy, non-punitive, and then connected to a partner. So if these things only happen when one highly motivated staff person remembers to do it, it's not going to survive the real world workflow pressure. Next slide. So the first strategy, like I talked about, naloxone is one of the most immediate overdose prevention tools that we have available because it absolutely can reduce an opioid overdose. So for pretrial context, the goal is not simply awareness. The goal should be making naloxone routine and easy to access for folks at the points where overdose risk is present. So that can mean offering it during intake, release, during court check-ins, or supervision meetings, and then also when there's conversations with family or support systems surrounding people. This can also mean having a standard script so that staff don't have to improvise. So, for example, you can say, we offer naloxone to everyone because overdose can happen quickly and naloxone can save a life. So it can be very standardized across the process, but just making sure that it's built into the workflow. And then the important implementation detail is that normalization. So if naloxone is treated as a marker of suspicion or of noncompliance, people are going to avoid it. If it's treated as a standard, piece of safety equipment like a fire extinguisher or a seatbelt, then it becomes easier to accept. Next slide. The next strategy then is medication continuity, and this is really critical for overdose prevention. Methadone, buprenorphine, and naltrexone are evidence-based medications for opioid use disorder, and having access to those medications does reduce risk. So for the pretrial services context, the key question is certainly not whether or not y'all are prescribing. It's much more whether or not the justice process is unintentionally interrupting that access. So again, a supportive question here can be, are you currently taking methadone, buprenorphine, or naltrexone? And then from there, you can help protect that continuity. So is there a court date that may conflict with dosing? Did detention interrupt medication access? Does the person have a ride? Do they have their phone? Do they have identification, insurance, things like this? All of those could be barriers to access for them getting treatment or continuing with treatment. And then this is also an area where policy really matters. So conditions or even informal practices that require people to stop taking their prescribed MOUD can definitely increase risk and undermine their recovery. So in this case, the pretrial role is really to reduce that friction and connect quickly to the right treatment provider. Next slide. So then the third lever is overdose safety planning. This should not ever be used as a scare tactic. So as we know from the intervention and sorry, can't think of what the term I'm grasping for is, but in overdose prevention research, we understand that fear-based messaging often does not produce the behavior change that we're looking for, especially when people already know the danger of, what they may be using, but then they're facing addiction withdrawal. They may have trauma. There might be a lack of options. So instead, a better approach is a practical, also respectful conversation about the next high risk transition. So again, does the person have naloxone? Does a trusted person know where it is, know how to access it? Do they have somebody that they can check in with or that can check in with them during high risk moments? Have they recently been abstinent? Have they recently been detained? Right? Both of which can lower tolerance. Do they know about local public health guidance regarding the drug supply? Do they understand the danger of mixing opioids with alcohol, benzodiazepines, or other sedatives, right? So this is not about approval of drug use. This is about keeping people alive long enough for treatment, recovery, family connection, and then, of course, court obligations to remain possible. Next slide. So a referral list is information, but a warm handoff instead is that connection. So for people leaving detention, also stabilizing after arrest or trying to reconnect to treatment, information alone is often not enough. So the barriers are just too immediate. Like I said, no phone, no transportation, no ID, no insurance card, no appointment even, and sometimes no trust that the system will actually help. So a warm handoff instead is the means to that next connection that is made possible before the person leaves wherever possible and wherever it can occur. This might look like scheduling an appointment, connecting somebody to a peer or a case manager, helping solve that transportation or phone barrier, and then confirming the connection after the fact. So again, we're not trying to advocate that pretrial holds all of these services in-house, but the skill is making that next connection a meaningful one for people and then building a workflow where partners know what to expect from each other and you've already had those conversations ahead of time. Next slide. Finally, data-informed prevention is another area where pretrial can be really valuable without becoming a surveillance agency. So the point is earlier and more coordinated action. Agencies might notice patterns before anybody else does because you're in that space. So repeated releases without medication continuity, for example, maybe seeing a cluster of non-fatal overdoses, people missing appointments because of transportation, knowing that there's gaps in the local naloxone access. These are all places that having that data and the data sharing can really inform what needs to change within workflows. So the safest and most sustainable approach is often to share aggregate or de-identified patterns with public health and public safety partners. And then for individual level coordination, agencies definitely need consent. We need to know what policy exists and then legal guidance. But trust really is part of the intervention. So if people believe disclosure will only be used against them, they're just not going to disclose, right? So if staff can explain why information is being asked of them and then how it will be used to connect to support, the same question now suddenly becomes a prevention tool. Next slide. Okay, so talking about the workflow, I've said this a lot. This is the step, though, that overdose prevention really becomes important within this context. And it does not, it can never rely on, one-off responses, as I mentioned. It has to be repeatable. So at intake, asking brief risk questions, again, normalizing naloxone, and then identifying whether or not a person is currently connected to MOUD, to treatment or recovery services. And then at release or first contact, again, offering naloxone, confirming medication access, and then addressing those practical barriers like the phone, transportation, et cetera. During supervision check-ins, reinforcement of the safety plan that we talked about, replacing naloxone if it's necessary. So again, that kind of check-in, check-up, really, really critical for that continuity. And then true troubleshooting barriers before they turn into crises. And then for crisis or for non-compliance moments, the key shift is to treat missed contacts or positive screens, even return to use as risk signals. So there still may be legal requirements in addition, but the prevention question is what safety action can we take before the risk actually escalates? Next slide. Okay, so now remember I warned you about this. Now is the time for practice. So this vignette is really meant to start thinking about that workflow and make the workflow concrete. So for this case, I want you to think about your own workflow, like what you have going on right now. I'm going to read the scenario, but in the chat, I want you guys to enter in if you feel comfortable. Just some things that you can do for each of these questions. So the scenario is that a 28-year-old client is released after 4 days in detention. Before arrest, they were using opioids daily and taking buprenorphine intermittently. They missed 2 doses in detention. They lost their phone and they're going to stay alone tonight. Their next court date is in 3 weeks. So from a purely compliance-focused response, that might only confirm that when the next court date is and supervision expectations. But from an overdose prevention approach, we would ask 3 additional questions. So first, and this is where get ready to enter, what can be done immediately in terms of safety before the person leaves your office today? So what is one action that you can directly do? Shelter assistance, love it. And it can be either here's what I can directly do in my workflow, or what a partner could do. So you could do that warm handoff or connection. Connect to our MIH team and get them dosed. Okay. CSB connection. Awesome. See, and these are things that just off the top of our head, immediately coming to mind. You're eventually going to have this more detailed conversation, right, with everybody who's responsible for workflow. And you can be more intentional about what that looks like. Transitional houses. I love that. Okay. Let's see. Make naloxone accessible. Maybe they're coming in hot. Maybe have some on hand to give to the client. Yeah, I love that. Refer to MH or DA services, medical resources, harm reduction resources where laws allow. Yes. And planning a warm handoff. Talk through the plan. Yep. The prevention plan. Absolutely. Drug checking if available. I love that. Provide resources for shelters and local doctors who prescribe the medications. Absolutely. Have them follow up with you daily. I love that. Okay, so again, that first question is that immediate safety plan. So then the second question that we ask in terms of overdose prevention is what medication or treatment connections need to be protected? So this could be, and what do you guys, absolutely feel free to drop them in there in the chat. But you're thinking about that same day call to a provider or a bridge clinic. What do you have access to now? Are there some things that you guys think of that you can implement in your workflow now? So I'm scrolling back up real quick. Safety contract. Okay, I love that. Provide naloxone, provide resources, call family or close friend to have them be picked up. Yes, and integrating families and friends, super, super important in terms of support. Provide them with a phone. Yep, if that's an option, absolutely. Help connect with the previous provider. Perfect. See, you guys you get it. Okay, so then that third question then is that warm handoff piece. Who closes the loop in the next 24 to 48 hours? What do you guys think? What's something that you can do before they leave to close that loop, making sure, especially knowing that this person has been using daily and has missed some doses? MIH team works through the fire department here and they will connect them to a provider for Suboxone. Okay, love it. Take client to provider. Awesome. If that's an option, absolutely. But again, we want to focus on that 24 to 48 hours being really critical because when we have these connection points, these clients really can be at some of the highest risk, right? That they may face for overdose. Coordinate with partner agency and follow up. Love it. Call provider while they are in our office to ensure they have a plan. Yeah, see, and these are really low barrier, low hanging fruit kinds of things that don't necessarily have to change a huge amount of your workflow just to make those little connections. And that is exactly the point. The point is for you guys not to solve everything, but to ask and then act on what is that highest risk transition for them. Discuss plan with the client and provider. Awesome. You guys are on it. Next slide, because I don't want to keep us forever, but thank you guys so much for participating and thinking through that. So I call this the Monday morning checklist. This is just a practical 30, 60, 90-day way to move from that kind of concept into routine. So again, sometimes we listen to really great webinars or we hear something and then we get back to our day and it goes away and we never think about it again. So I'm encouraging you guys to really be intentional, because again, this is what Lindsay and I do every day, but I know it isn't necessarily something that's omnipresent on your guys' minds. I would love for it to be for at least a few minutes so that we can maybe, help a couple of clients, but that 30, 60, 90. So 30 days in, go ahead and map your local safety net. So where does naloxone come from? A lot of folks mention naloxone in the chat, and I've talked about it a lot, but where do you get it, right? Do you have a plan? Is there distribution that already exists that you can tap into? Another one is that MOUD access. So, are there providers who can accept people quickly? Sometimes it can be hard to, get an appointment in. Are there bridge clinics? Do you guys have peers in your area? Are there crisis response teams or mobile outreach partners? So just identifying what that safety net might look like initially, and then moving over to the 60 days, this is where you build out that workflow, right? So we're going to create intentional standardized scripts. We're going to identify when naloxone is offered, decide how often warm handoffs may happen, and then clarify those privacy guardrails, okay? Then for 90 days, we want to measure and improve. So this is where we're going to track process measures like we're offering naloxone kits. How many were distributed? How many were refilled? Because once we distribute, if people are using them, making sure they have access to get it again. How many appointments were made? What kinds of warm handoffs happened? And then what barriers were identified as well as fixed, right? So if you see something come up, making sure to note it, see where we can include some additions in the workflow. And then again, starting with that highest risk transition point that your agency touches most often, right? So a small but reliable workflow is much better than this big ambitious plan that no one can really implement. Okay, next slide, Lindsay. So my closing takeaway is super simple. I am aware, and you guys are aware, that the pretrial role is not to treat addiction, but the role absolutely is to make survival and connection more likely at every contact. So that means identifying risk without increasing punishment, reducing lethality through naloxone and safety planning, preserving access to treatment, like we talked about, and then strengthening connections to partners who can provide care. So when this is done well, it's not stepping out of the pretrial mission, so to speak, right? They are supporting court appearance, community safety, health, and stability by reducing risk that a preventable overdose interrupts everything else, right? Next slide. So I've included the major sources and implementation resources here. These are all clickable. And I saw somebody ask about the slides. You guys will definitely have access to these after the session. These resources support the core strategies we talked about. So naloxone access, MOUD, linkage to care, reentry, overdose prevention, and then things like fentanyl and xylazine awareness. There's some stuff in there about Good Samaritan policy considerations, and then public health, public safety partnerships. The important caveat is that implementation should always be aligned with your local protocols, with legal guidance, and then the current state policy. As Lindsay mentioned, our ORS partners, the DIOs and PHAs, can absolutely help you identify who you can connect with in your jurisdiction. And if you guys need any help connecting with your DIO or PHA, please let us know. You can reach out to Lindsay or I, and we can absolutely get you connected with who your person is. But I'm going to turn it back over to Lindsay to finish us out.
Excellent. Thanks so much for that amazing presentation, Sydney. And yeah, really tying it back to the beginning when I gave that overview of the ORS and kind of shared the core of our program, the teams, even going back to what Sydney was talking about, that Monday morning checklist, if that feels overwhelming to start with, our teams can absolutely help you. That's what they do. They find those partners and those connections in the community. And so, that's one example of where you could work with the ORS team to start building out some of those strategies and processes into your workflow. So just wanted to flag that. So now we're going to shift gears a little bit. Again, as Sydney said, we really want you to walk away with some, tangible things. And so I shared about the core of the ORS, kind of the functionality of the ORS, but now I want to share some opportunities that you can engage with us at different levels, more from the training and technical assistance side. As Sydney said, if you have any direct questions for us, we'll in the follow-up slides, we'll include our contact information. But here's some other kind of more virtual opportunities to connect with our program. So as I mentioned at the beginning, I'm the training technical advisor. Myself and the training technical lead are kind of two halves of the whole training team within the ORS, but we obviously get support from our public safety partners as well as the rest of our national team. And so what overdose response strategy training opportunities look like. So we have a monthly training webinar that we offer to our ORS teams, and oftentimes we open those up to partners as well. And this is on, a myriad of different topics. It really is dependent upon, the immediate needs, any emerging things that come up, or what our teams are asking for, what's coming up within their partners. For example, we just had a lot of conversation about K2 and Spice in jails. And so our next session will be around that. Just like I said, we really try to focus our training on what the need is. I'm sure that's what Wendy does with you all as well. We have our skipping learning communities because we're going to dive deeper into that, but we have our learning intensives, which are a deeper dive than just a one-time webinar. They're really meant to spend a couple more sessions really diving into a topic. So example of one that we had recently that was open to partners was our deflection, diversion, and situation tables. We had a 5-part learning intensive session where we invited experts from across the country to come really dive a little bit deeper in how to work within each of those different strategies, the deflection, diversion, and situation tables. And again, sometimes, often we open those up to partners as well. And then our learning communities are more long-term communities of practice. We have 5 learning communities, which I'm going to dive a little deeper into, that we really have a pointed focus for each of those. And again, there's often opportunities for our ORS teams to invite their partners to this. So if each or any of these seem of interest to you as I go through them, at the end, you'll have an opportunity. There's a QR code where you can sign up and say, I want to be part of whatever thing that there is within the ORS. And lastly, we have an annual ORS conference every year in May. And this is our in-person opportunity. We always welcome partners to come, but that's really an opportunity just to dive deep into what's happening within the ORS, share out some of those new and emerging practices, best practices, and really connect together around this topic of overdose prevention at that public health and public safety nexus. So as I promised, a little more information about the ORS learning communities. And so the purpose of the Overdose Response Strategy learning communities is to provide an opportunity for program-wide networking across the ORS and with partners, and to connect around targeted and effective strategies to address fatal and non-fatal overdoses. As you can tell, the theme here, that really is our North Star and our mission. Our learning communities provide space for shared learning across members of the program and oftentimes their partners, so that we're all better equipped to support the programs and other partners in their respective states and territories. So diving a little bit deeper into our learning communities. So our first learning community is our data learning community. And really the purpose of this is to share out emerging tools or existing tools, do training around that, help our teams and their partners learn how to more effectively use data visualizations to tell a story with the information they have. We do a lot of work where we tie in how AI can help in our work. We did a really great series with that as well. So that's kind of the overview of the data learning community. And as Sydney had mentioned, you'll have access to these slides. So I'm kind of going through these quick. I think the two learning communities that will resonate more closely with the roles that you all have is the Justice Continuum Overdose Prevention Learning Community that I lead, and the Overdose Prevention and Policy Learning Community that Sydney leads. So if I rush through these a little bit, promise you'll have access to these slides, and you'll have access to us as well to ask any questions. Next, I'm going to share a little bit about the Justice Continuum Overdose Prevention Learning Community that I mentioned. Again, this one is the learning community that I lead. Previously, this learning community was overdose prevention in jails, and we realized that we had an amazing opportunity to connect with health management associates and dive really deep into the subject. We amassed a lot of great knowledge and have tons of training products from this, and we realized that we were kind of missing out by not addressing all of the opportunities across the sequential intercept for supporting justice-involved individuals that have SUD and mental health issues. And looking for opportunities for diversion and, like I said, that ongoing support. And so the purpose of this newer evolution of this learning community, again, I think this one might be of interest for you all, is to look at each of the intercepts across the sequential intercept model and really dive deeply into the programs and strategies that can work within communities to support justice-involved individuals with SUD, really look at opportunities for deflection and how those can be implemented, and work with national partners, national, state, and local partners across the country who are doing these things well, to share that out with our teams and partners. We have a quarterly partner call with this learning community, and so would love to have you all come join us and hear what we're talking about in this space. Some of you may be familiar with this next one, overdose fatality review, or OFR, and public health and safety teams, or FASTs. The purpose of this learning community really is to dive deeply into OFR and FAST, talk about national strategies and the standards, talk about what works. Again, we're really big on that. We look at the ORS, the beauty of the ORS is that we have such a large network. And so we can really dive deep into what is working well and then share that out with our other teams and their partners. We're currently in a partner call sessions with the overdose fatality review and FAST learning community. So again, if that's something that's of interest to you, if it's something you've heard or asked to be part of, this is a really great resource to kind of dive deep into that and understand it a little bit better. As I mentioned, one that's a little more probably relevant to you all on the call is Sydney's Overdose Prevention and Policy Learning Community. And it really expands ORS expertise beyond that primary prevention by focusing on advanced overdose prevention strategies, drug policy, and cross-jurisdictional collaboration. And the learning community aims to equip the teams and their partners with practical tools to implement evidence-informed approaches that reduce fatal and non-fatal overdose. Sydney, I don't think that really does justice to what Sydney does in her learning community, but as a broad overview, that's kind of the absolute aim, looking at those, diving deeply into those secondary and tertiary overdose prevention strategies. And again, showing how they work, and sometimes when they don't, and how to pivot from there. And lastly, our overdose response learning community. This one really focuses on overdose spike response and preparedness by building expertise in planning, coordination, evidence-informed interventions, and that tailored technical assistance. This one actually over the past several months has been very rooted in that partner collaboration. We have had an entire learning cohort where our partners and teams have come together to talk through what spike response planning looks like in their state or their community. And so this learning community really does promote that peer learning, not just among our ORS teams, but among partners as well, and helps identify effective practices for responding to overdose spikes. So that's our learning communities in a nutshell. Again, I know I went through that very quickly, but you'll have access to these slides and access to us if you have more information or want more information about those. So some other learning opportunities, I had mentioned this earlier when we talked about the data sharing is kind of one of our core strategies. We have a national ORS trends analysis and threats webinar. And this webinar is bi-monthly, and it really is focused on delivering briefings that are on current and emerging drug trends. We offer access to experts leading forensic and toxicology labs, as well as those that are at places like the DEA labs and other agencies like that. And really the goal of this is to have a nationwide and a regional look at what overdose trends are looking like. Not just overdose trends, but drug trends, drug trafficking trends, anything in that realm that is of interest to our partners and kind of that really need to know to help really inform the work that everyone does. And we have this is open to any discipline. We have people from any different, like I said, any discipline. My words are escaping me right now, but yeah, this is a great opportunity for learning, and highly recommend sitting on one of those if you're interested in maybe viewing what it might be like for these. This website here, it's on our ORS website. You can access past webinars and kind of see what the cadence of them are and the type of information that's provided to see if it's of interest of you. Something I want to plug, just again, sharing a little bit more about the ORS. ONDCP and CDC highlighted the role of the overdose response strategy. And I think that kind of speaks to the work that our teams do. So just wanted to kind of do a shameless plug for that if that's something you're interested in learning a little bit more about. And lastly, connect with us. We would love to stay connected with you. As we've mentioned many times before, our teams are the core and you have access to them. I know you've probably heard before the joke, like, I'm here from the government, I'm here to help, but we really are. We're free help. Our teams are really eager to advance overdose prevention work in their state. And so when you get access to these slides, if you hover over the interactive map, you can have it'll take you to the website, to this interactive map, and you can hover over your state and you'll find out who your teams are. You can find that on the ORS program website. And then, as I said before, if you scan the QR code on the right, sign up for learning opportunities, you'll be able to select any learning opportunities that you'd like to be part of the listserv for, and we'll make sure that you get access when we have those partner calls. And I think that is it for us. So what are your questions? Oh, and thanks, Sydney, for popping those in the chat. One last thing, I know I threw a lot of QR codes at you, but as always, let us know how we did and let Wendy know how this session was. That feedback is really critical to continuing to provide the best type of content for you all. So wanted to also plug that. And I know Wendy will also be sharing the link for that.
Absolutely.
Yeah.
So just wanting to encourage folks, if you have any questions, please throw those in the Q&A right now. This is a wonderful opportunity for them.
Yeah, and Robin says in the chat that this aligns with some discussions that they're having with the agency and city this week. So that's perfect. And like Lindsay mentioned, if we can help you guys in terms of technical assistance, if you're having a meeting coming up and you're like, I don't know how to start these conversations, reach out to us. We absolutely can have those conversations and, chat through what might be the best approach. Yeah, I'll drop mine in as well. But let us know, what other things are you guys thinking about too? I know we have a little bit of time, so we could talk through, if there's have there been any barriers or any specific questions that have come up in this space, or even things that you've done that have worked well that you want to share with your peers? Go ahead, Lindsay.
Yeah, real quick, Cindy, to your question, like I said, we're from the government. We're here to help. We're not really from the government, but we are free.
We
We're
are free.
funded through we're funded through the CDC through that cooperative agreement, and so we really are here just to provide technical assistance and advance the work of overdose prevention across the country. So, yep.
And great question. Thanks for asking that. Yeah, because I know how that can be sometimes. But no, we are free. Let's see. Good. I'm glad you guys are finding it useful.
Oh, and that reminds me why we are your brains are getting going with your questions that I know you're going to be putting in the Q&A. If you want to hear more about this topic and a little bit deeper dive into kind of the neuroscience of addiction, you will see myself and another one of my colleagues at your conference coming up. I'm really excited to be presenting there again, kind of expanding on the information that we talked about today and diving a little deeper, like I said, into some more of that neuroscience of addiction along with some other strategies. So just wanted to plug that because we're very excited to be able to support in that way as well.
Awesome. And then just additional comments. Kenneth mentioned that they recently got the MIH team and they are saving lives. Before that, there was a huge, yeah, barriers to immediate help. So exactly, I love that. Thank you for sharing your experience because, sometimes, like we said, there really is some low-hanging fruit sometimes that can be free or, minimal cost or just a tweak in your process that can really make a huge impact for some of these clients. So appreciate you sharing that. Um, yeah, yeah, and feel free. Robin says she's going to share, when the recording and slides are available, absolutely do so. And if they have any questions, feel free to pass on our contact information as well. So awesome. Well, anything else? I mean, feel free, if people have ideas or things to talk about, we are here for you. So we want to make sure that this is valuable for you guys.
Yeah, so we will probably wrap up here, but I'm gonna give you guys another minute or two because I see a lot of thank yous and that kind of thing. We do still have time for questions, so feel free to put those in. I'm just gonna talk about a couple things. So Lindsay and Sydney had provided their contact information in preparing for this. I want to reiterate just how open they were to. We hope people reach out. They can both help talk about today's webinar as well as connect you with the people that are available in your state or in your territory. I know lots of times we have folks join us from Guam. So Guam folks, if you're on today again, there is someone in your area that works with the CDC Foundation and with or us here that can help you. So definitely please reach out. And then also just to kind of follow up on the stuff just about conference, we're thrilled to have Lindsay coming to the conference with her colleague and so many other wonderful sessions. So if you haven't registered, please do. Early bird ends on Monday or after Monday. And otherwise, I don't see. Oh, there are two. What do we have in the Q&A here?
I just see, I see there's two, but only see one question.
I think
Yeah.
it
Oh, I think
was.
it's never mind. I see the bottom of it.
Yeah.
So there's a couple recommendations for this. Every state's a little bit different, but typically most states have state opioid response funding that is provided either regionally or at the state level, and they provide naloxone through that. And so looking, and if usually you can do a Google search to find it, but looking depending on the state that you're in, what that looks like, what the naloxone distribution mechanisms or routes are, can be one way to get naloxone kits regularly, so you have them in stock. Sydney, do you have any kind of other recommendations other than that?
Yeah, that's exactly what I was going to mention. If you guys, if you have a specific state, we can help you drill down to what that is. But so like I live and work in Arizona, and so the first thing that comes up when I Google like naloxone access, it does, ping to our SOAR grantees. So wherever you are, if you put in like your state name and search for naloxone, there probably is a state agency that runs that. And often they have it's completely set up to be able to distribute. Again, it really depends on how funding is allocated, but to the point in the chat, if there at least are places that you could refer people to get, like sort of one-off, but definitely creating that partnership should be part of the investigation of your workflow, to make sure that you guys have naloxone available or know exactly who to send people to so that they can get it like then. But court systems typically can become a vendor and get access to free naloxone through your state opioid response grant. In Virginia, probation officers are recognized as first responders. Yep, for naloxone. Now we just need community corrections offices or officers to support it. Yeah, and this can be part of that stigma piece. So I think the more that we talk about it, the more you include, this kind of conversation as just the standard sort of, it's almost like if you kind of breeze past that and move right into this is the practice because it is the most evidence-based, it can kind of lend credence to that. So if you need some support, also Virginia is pretty advanced when it comes to some of the way that they've spent their dollars. Virginia was also the location site for my dissertation research, so it's lovingly in my heart. So if you need specific support when it comes to any of the states, reach out to us. We can totally do that for you. But like this, how we do distribution and what process to go through to get us to that point really can be individualized per jurisdiction because it really does depend on what the culture is like, what your government system looks like. There's just a lot going on. And the fact that you're bringing up Virginia, and it is a commonwealth, right? Not even a state. So different approaches for different areas, for sure.
Yeah, and I also, just to add to what Sydney was saying, our Virginia team is very strong too, and can provide that additional support as well.
Yeah, great questions though.
Yeah.
What else are you guys thinking about?
All right. Well, we will give it while I'm kind of actually to Lindsay and Sydney. Any last words before we wrap up? If you have questions though to the participants, we do have time. Go ahead and throw them in the Q&A. Otherwise, if there are no questions, we're going to wrap up. But Lindsay and Sydney, any last words?
Really just again, thank you all for your time. I know we put it in the chat, but as Sydney said, your time is probably stretched very thin, and we appreciate that you took it to spend it with us and learn a little bit more about our organization as well as the work that we do in overdose prevention and how that can really apply to your work. Sydney, on to you.
Yeah, I agree. And just I really feel like there is something to be said for you caring just a little tiny bit, right? And so having that entrepreneurial spirit of how can we make this a little bit better for our clients is the step, right? And so the fact that you're even here and attending like already shows that that care and attention are there. So just, I would encourage you to have the conversations that you can and influence who you have access to. And if you need help or ideas, reach out to us because we're more than happy to have those conversations with you and, try to think through what the best options might be for your individual area. But yeah, thanks for the opportunity.
Something I had forgot to mention too is I said this early on, but working in the justice system, specifically in that pretrial space, is a newer partnership and something they're really hoping to grow. And so, again, just I know we keep saying it over and over again, but use us as a resource. We really want to continue to build out this partnership and be able to help in this space because we do have experts across the country, specifically on overdose prevention in that public health, public safety nexus. And so, just wanted to really advocate for the partnership and using the resources that exist.
Yeah, and Carolyn asks if you can, I'm sure Wendy can throw our emails into the response email.
I don't actually, it's an automated response. So if you could toss your emails into the chat one more time, that might be the most efficient. And then otherwise, Carolyn, they will be, once I get everything uploaded onto the website, all that information will be available. Here I'm putting the chat or in the chat, the previously released NAPSA resources. We'll have the video as well as the slide deck that contains their contact information there on our website.
Yeah, and Wendy, I'll send you an updated slide deck that has that email on it.
Awesome. Great. And it looks like Carolyn and Jody and Renee are maybe wanting to connect with you, and Albert. Oh, and then maybe Megan. Oh, yeah, there we go. There's several. There's quite a few. So just to be clear, I won't be sending individual emails. You'll get an email from Zoom that is automated that will come out with the survey link, and then you can find all the contact information in on the website. Typically, I would say most likely that'll be up by tomorrow. Sometimes if there's a delay in Zoom or something, it should be for sure by Friday. So. Okay, anything else? Just thanks so much to Sydney and Lindsay. This has been an excellent presentation. I learned a ton, and the knowing how big your hearts are and wanting to make a positive impact, and then like you said, all the folks that came today, really wanting to help people. So I'm really grateful for everybody to be here today and for you guys taking your time. Um, uh, Join us. Like I said, we'll pick up our webinars most likely in October, so keep an eye on the website. And otherwise, I hope everyone has a wonderful day. Thank you so much.
Bye, everyone.
Bye. Thanks, guys.